Hello, my name is Nikki Nemode. Today I'll be sharing the sleep interventions in hospitalized patients presentation I've prepared for you. So why do we care about improving sleep? Insufficient sleep has poor physiological outcomes in both healthy and sick people and leads to decreases in immune function, which is incredibly important in hospitalized settings where there's an increased risk for sepsis, memory and cognitive function, wound healing strength, insulin sensitivity, pain tolerance, and survival rates. All of these contribute to longer or more frequent hospital stays. Hospital stay length and frequency is a huge public health burden. Of the $377.5 billion aggregate hospital inpatient costs in 2012, 62% were paid for by government taxpayer funds. The burden of poor sleep in hospital stays is significant. More than 37 million patients are hospitalized annually in the United States, and improving sleep is a huge, huge priority across many disciplines for many different reasons. Sleep is vital for restoring health and well-being, but is yet frequently interrupted during hospital stays. The average sleep duration in a hospital stay is 2.5 hours shorter than reported normal sleep. The biggest culprits for this are noise, staff interruption, and circadian disruption. Billions of dollars are spent each year renovating and construction healthcare programs and facilities. It would be in the best interest of everyone, the hospitals and the patients, to consider best design and practices for sleep and the greater population of elderly people in hospitals, especially baby boomers, as they decline in health, their needs will become more and more burdensome as the population number increases. From a financial point, hopefully some of the interventions I address can be considered in the renovation and construction of newer buildings. However, the primary risk factors that I'll be investigating are external factors, but overall risk factors include age, personal factors, and external factors. So age, overall, the quality of sleep decreases as we age. Here we see two hypnograms. The top one shows young adults and the bottom shows elderly. For those who are not in the sleep field, what this essentially shows is the sleep architecture, so the different amount of time spent in each stage. So as we can see, there's less time spent in REM sleep, which is needed for cognitive repair. We also see a longer time in sleep latency, so it takes longer to fall asleep, more awakenings, more arousals, and an overall decreased total sleep time, decreased time in REM, and decreased time in slow wave sleep, which is very good for rehabilitation. And then we also want to consider the external factors. And the external factors that I'd like to consider are noise, medication, timing, and lighting. In an earlier intervention study, they asked patients what was keeping them awake, and the biggest concern was hospital staff. Other concerns included discomfort, noise, and attached equipment and worries. So I like to consider a three-pronged approach, including noise, medication, timing, and lighting. Lighting hasn't received as much attention, but because of the knowledge I have on circadian alignment, I know that light is the biggest mediating factor. Additionally, hospitalization in and of itself is a risk factor for poorer sleep for reasons like anxiety and unfamiliar setting, and also the external factors that I mentioned, including noise, light, and interruptions. So 66% of in-hospital sleep quality is low, and 67.5% falls below the threshold for insomnia, indicating poor quality and quantity of sleep. The most affected population is older adults. Their in-hospital sleep duration was 2 hours shorter than their younger fellow patients, and their efficiency 14% lower. So other intervention studies that I found look at their primary outcome was sedative use, but instead of looking at that, I'm going to look at objective measures of sleep. So earlier studies have established quiet time from 10 p.m. to 6 a.m., changed vital routines to morning and night, and educated physicians to change the order of their medications to be comparable at bedtime and wake time instead of every 24, 12, 8, or 6 hours. Not administering diuretics after 4 p.m., which make you need to urinate and interrupt your sleep, avoiding events that have loud monitoring systems, installation of noise detection systems, notifying that it's bedtime by playing a lullaby over the PA system, dimming the hallway lights at 10 p.m., and encouraging nurses to follow bedtime and wake time procedures. The Hospital Elder Life Program noticed a 24% reduction in sedative use, and there is a 39.3% decrease in sedative use in the Somerville protocol, and 61.2% decrease in sedative use in hospital elderly. Sedative use is a big factor because it leads to poor cognition, performance, dizziness, falls, and confusion, and also includes insomnia after discharge. I'm hoping to achieve similar results, but I want to be able to interpret them based on the quantity and quality of sleep measured objectively. Many of these measures used objective measures such as questionnaires. They're very strong in the fact that they're community-based, non-pharmacological, and involve the use of healthcare providers and the HELP program used biomarkers, particularly blood pressure. But they are limited because they present a high cost and, like in the HELP one, or a high burden on hospital staff. They lack objective measures, and their controls are measured at a separate time frame from their intervention studies. The objective of the study I'm presenting is to determine if behavioral interventions increase quality and quantity of sleep measured objectively using actigraphy and polysomnography. The study design I will use is a community-based random trial. It will be carried out by Mount Nittany Medical Center staff, including physicians, nurses, and others. I chose a community-based approach because each hospital has its own considerations. For example, Mount Nittany Medical Center is adjacent to LifeFlight, which presents its own noises, and possible alarm systems may present at different frequencies, general acoustics, room and ward setups, and the already in place routines of hospital staff. I've selected a sample size of 90 using 45 cases and 45 controls that will be conducted in 9 waves of 10, so there will be 5 intervention and 5 controls over 9 weeks, and they'll be at opposite sides of the wing. And I want to look at the most vulnerable population, which is the elderly. I will, however, be looking at the medical surgical unit and excluding any end-of-life and ICU patients, anyone with sleep disorders, language barriers, prior day surgery, drug and alcohol withdrawal, hearing loss, and blindness. The intervention I'm suggesting is to implement a 10 p.m. to 6 a.m. bedtime, and during this time, there will be rules to close the patient's doors, and there will be installation of flashing noise meters for when you go above 60 decibels to remind staff to talk quieter, and also to indicate any times that there are breaches in this that exceed 60 decibels. We also want to minimize interruptions by using a bedtime routine for care and vitals, and administer drugs based on bedtime and wake time instead of the Q12, Q24 type designation. Also, a newer aspect that I'm interested in is light. Like I mentioned, your body adjusts its circadian rhythm based on light exposure. So I'm going to suggest opening the blinds or providing artificial light during the day to coincide with the sunrise, and then close the blinds and shut off the lights for bedtime. Controls will not receive the intervention and will be located at the opposite side of the wing. I will measure this using polysomnography, PSG, to measure electroencephalogram, electromyogram, electrooculogram, and EKG to determine sleep architecture. And this will tell us the total sleep time, sleep efficiency, sleep onset latency, and wake after sleep onset. I'll also use actigraphy to measure these same variables, but the downside is actigraphy does not have the ability to tell us sleep architecture. However, it is inexpensive, non-invasive, and has been validated by PSG. This will be an additional validation measure for this population. I'll also be administering the Pittsburgh Sleep Quality Index, the PSQI, at the beginning to identify patients as good or poor sleepers, and we'll be able to stratify by this data at the end of the study. The outcomes I'm anticipating are going to be sleep architecture, so an overall picture of the night of sleep. And then I'm going to expect, so this differs as we age, so I'll have that accounted for, and we'll only be comparing this among older adults. I'll be looking at the total sleep time, the sleep efficiency, so how much time is spent between lights out and lights out sleeping, the amount of time it takes to fall asleep or sleep onset latency, and how much time is spent awake after falling asleep, known as WASO. I'm anticipating that the sleep architecture will show more overall sleep time and additionally more time spent in REM, which is better for cognitive repair. I'm expecting an increase in total sleep time, an increase in sleep efficiency, a decrease in sleep onset latency, so it's easier to fall asleep, and then a decrease in the time spent awake after sleep onset. This is the first use of objective sleep measurements with these types of interventions and in this population. I'll expect similar changes over controls, but not to a significant amount. The controls will also improve in their sleep as they become more comfortable in the hospital bed environment. I plan to compare the mean values across these and stratify it based on age, gender, PSQI, and BMI. So I'll be able to look at the older and the younger, so the 65 age group, 70, 75, and plus, and predict that poorer sleep will be found in those who are older. It'll be pretty consistent among gender. I'll expect that the poor sleepers will have more room for improvement, but overall lower levels, and that those with higher BMI will have poorer sleep. There are some other positive effects possible in the study, and these include an increased knowledge and awareness of sleep health by healthcare providers, better sleep hygiene in the community, and repeatable methods that can be used by other hospitals. So this brings me to my strengths, which is that these are easy to implement interventions that are low burden and inexpensive. They're non-pharmacological, so there will be very, very minimal risk or side effects to any of the patients. And my greatest strength is that this is an objective measure, so it's likely to be repeatable, and studies can be found in other hospitals that test it similarly. We're limited by the size of Mount Union Medical Center. It's small, so this limits the number of subjects that can be studied at one time. Sedentary behavior, like in hospitalized elderly, is hard to detect via actigraphy, so PSG will be used as well. First night effects will be held account and will be expected, but that's why we've accounted for multiple days in the study. The study is dependent on hospital staff and patient compliance, but I do anticipate high levels of implementation because the hospital staff at Mount Union Medical Center are great at promoting health and positive health outcomes. I hope you enjoyed my presentation. I'd like to acknowledge the others at Penn State Sleep Health and Society Lab for giving me a strong foundation and interest in sleep and the valuable resources I've used. I encourage you guys to feel free to ask any questions, and I'm looking forward to hearing your presentations as we wrap up the semester. Thanks for listening.